come on. Oh, there it is. What the hell? Why isn't this charging?
Oh, yes, please don't.
Charge.
Good evening. So we're right at that time, huh? Okay, so we'll get ready to get going here in just a second. If you would, please make sure that you put your name in the chat box for me so that I know that you are here. And tonight we'll be playing with the second half of basically a child with acute condition. So with that as we move on. So I'll run the same format basically as it was last night. Get myself all set up here.
Okay. Oh, God.
All right, so let's see. There we go. All right, so I have basically we have urinary disorders. So, you know, if you remember back to term 3 when they were talking about renal disorders and everything of that nature, basically a lot of this will come in because just remember with children, it's pretty much the same as it is with adults. You know, it's just that they go critical faster. So you got basically got minimal changes with nephrotic syndrome. So basically the minerals become permeable to protein, primarily albumin, which reduces the serum albumin levels and lowers the serum osmotic pressure. So if you think about it, the kidneys are the primary source of controlling water balance within the body, right? So we have a problem with kidneys. Now we're going to have a problem basically with fluid or with water balance within the body. So we're going to have less water in there. If they're voiding too much, if they're voiding too little, then we go into fluid volume overload. Now here with this, the kidneys becoming permeable, so now it's letting large proteins basically, which shouldn't be coming out. So if you think about it like it's saying, you know, you got the albumin. So remember, albumin is a protein, and of course, you know, it's talking about reduces serum albumin levels. So when it's talking about serum, you know, that's basically the blood that's running in the veins and arteries, right? So when we draw a lab that's a serum value, that's where we do a venipuncture, we pull the blood out of the veins. So, and then of course, if you remember about albumin has a couple of major things with it. Number one, albumin is an indicator of nutrition. That's one of the things we can look at to see how well the person has nutrition levels. But also albumin causes osmotic pressure basically in the vascular space. Otherwise, the albumin is what helps hold the plasma or basically the fluid portion of the blood in the vessels. So if the albumin level drops, then what happens is fluid can then leach out the vascular spaces in the capillaries. It can leach out the capillaries and then go into interstitial tissues. which can compromise the cardiovascular system as well. So just, you sort of have to put all this stuff together because, if you watch when we're talking about this, we're talking about the kidneys, but we also see this impacts the cardiovascular system as well, depending upon what's going on. So basically here, contributing factors. So a lot of times, like it says, it occurs primarily in preschool children. Peak incidence is between 2 and 3 years of age, basically often preceded by viral upper respiratory infection. So when we have young children and they've had this viral upper respiratory infection, then we watch out because they can develop this condition. And so like they say, you can see over here on the right side, it talks about the common causes of nephrotic syndrome in children. So, idiopathic, remember idiopathic means they don't really know, it's unknown. And of course, drugs, neoplasms, infections, allergies are secondary causes that can create this to happen. So expected findings. Well, like I said, if you watch, right, like I said, albumin is what keeps the osmotic pressure that basically it holds fluid portion, the plasma portion of the blood in the vessels where it belongs. So when the albumin level drops, that fluid is going to start leaching out through the capillaries, going into interstitial tissues. And so, if it does that, we're going to start seeing edema forming in different areas of the body. So, that's why you see, facial puffiness, especially around the eyes, seen upon rising in the morning, dissipates throughout the day. So, basically we see the puffiness or the edema forming. You got swelling of the abdomen, genitals, lower extremities. Basically, of course, it says more prominent during the day. And of course, if you think about it, that's because fluid's leaking out of vaginal space, going into interstitials, and it's creating edema or basically in these areas. And then you got gradual rapid onset of anascardia. Basically, an anascardia just basically means generalized edema. So basically, they can have edema formation all over the body or throughout the body. So expected findings, we can see ascites. So remember, ascites is third spacing of fluid. Basically, a lot of times we see abdominal ascites where we get that fluid that builds up in the abdominal cavity, and we can only tell it because if you tap the abdomen, you'll see like waves of fluid moving across the abdomen. And remember, in order that develops, and basically we have to do a paracentesis, basically in order to pull that fluid out. They can have diarrhea and anorexia. So basically, dark frothy urine, decreased urinary output, extreme pallor, fatigue, and irritability. And if you think about it, a lot of times, the fatigue and irritability can come on fairly quickly with this, and of course, then all the other stuff starts to move along the lines with it. So basically, as we hit the wrong button. Okay, so anyhow, as we continue, they can have I'm not going to pronounce that word appropriately, but that's white lines in the nails, increased susceptibility to infections, hypoalbuminemia, so that's basically low levels of albumin in the vascular space, hypercholesterolemia, so that they can have high cholesterol levels, massive proteinuria, so they got a lot of protein in the urine, and of course a high specific gravity. And of course, if you remember the kidneys are becoming real permeable. They're letting a lot of large stuff that normally shouldn't be getting into the urine. They're allowing that to get in there. So of course, specific gravity looks at the particle matter in the urine. So we know that the particle, based on my specific gravity, will be real elevated because of this happening with it. And of course, the hyaline cast. So with expected findings, so we can see increase in platelets. So they go 500,000 to a million, basically. And of course, remember my normal platelet levels, basically, 150,000 to 400,000. So the platelets are going to decline. And of course, the hyponatremia. So if you think about it, that's low sodium. And so, it can drop down to about 130 to 135. If you remember, normal range is like 135 to 145. And then you get hypocalcemia, basically low calcium levels in the blood as well. And if you think calcium is also a major electrolyte player that plays with involving the muscles in the heart. So, if my calcium levels drop too low, we can start seeing other problems within the body as well. So it's just sort of a photo so that you're able to see it, basically how the normal glomerular works, and then of course the one that's hitting in there, basically what happens, it becomes more permeable, and what happens is this is where the proteins, albumin and stuff, are leaching out into the urine instead of being recycled back into the body. So basically lab tests, and also basically with this, if you think about it, we know that it impacts albumin and protein, so we're definitely going to serum protein and serum albumin. And of course, you see serum, so you know this is going to be a venipuncture. We're going to draw blood from the vein to run the test. And then, of course, we're going to run an electrolyte panel, so I know they're either going to do a CMP, a comprehensive metabolic panel, or a BMP, a basic metabolic panel, to check the electrolytes, basically, CBC, lipid panels, urinalysis, specific gravity, renal biopsy, blood urea nitrogen, basically your BUN, and creatinine. So our intervention, one, we want to engage in quiet activity. We want to keep the child calm. We want to monitor strict I's and O's and monitor urine for protein. And of course, we definitely need to monitor for edema. So we'll be doing daily weights and daily measurements of the abdominal girth. So like I said, yesterday and stuff, if you're on, right, we're looking for the abdominal girth to see if we have swelling or distension in the abdominal cavity. We get out the paper tape, put it at the belly button, and we go around the whole area, and then we measure to see what the measurements are. So, and then this way here, we can tell, is it getting worse or is it improving? We want to monitor skin integrity, basically. And if you think, like I said, a lot of this is the same stuff we do for adults. Right? If you remember this back in term 3 in the renal section, most everything we're doing for the most part is pretty much what we would do for an adult as well. And of course, we monitor skin integrity on patients, and because of the edema formations and everything else, that puts them at a greater risk of having problems with the skin. And of course, we monitor vital signs in everybody, right? So that shouldn't be an issue. That should just be sitting there all the time. And then, of course, protect the client from contact with anyone who has an infection, because these patients are real susceptible to infection. So basically, if they have this condition, we may need to put them in a private room, or we can house them in another room with somebody that maybe is coming in just to have x-ray exams or something like that. But we wouldn't want to put them into a room with somebody. We wouldn't want to cohort them, basically, in the room with another patient that has pneumonias or some other type of infection, because there's a probability that this patient could also get that infection as well. Elevate edematous parts. So, right, if we have swelling or edema, right, typically if we elevate it, that's what helps reduce it. So if I have edema in the feet and ankles, just like if I had swelling there from an injury, then we would elevate that aspect to help pull that edema out of there and to reduce that amount of swelling or puffiness in that area. And then clean the skin and separate the clothing, cotton or antiseptic powders. Maintain low sodium diet and consult with dietitian to provide palatable foods, basically. So finding foods that the patient will eat. Basically, after the edema subsides, allow the client to resume normal activities. And of course, remember, if somebody has edema, basically wherever the edema is at, we do not want to be in a dependent position. We would want to be into an elevated type position to do it. And of course, if you think about it, if the child has edema of the face going on, right, how would you elevate the face? Or how would you elevate the head? Anybody got an idea?
Elevate the face or the head?
Oh, y'all out there? Did I lose you?
Still here.
Okay. Well, if you think about it, the way I'd elevate, if you think about it, if somebody has throat surgery, right, we're concerned about swelling it, close off the airway, so we need to elevate the head and neck, right? So basically, if they have facial puffiness and all, the way we elevate it is we put them into a Fowler's position, right? We just raise the head of the bed up because then that would elevate the head to help with the drainage. You're pulling the edema and the extra fluids out of that area. So, you can, if you just think about it, just like, if I have edema in the legs, I'd elevate the leg side, elevate the foot of the bed, or I may have to put some pillows underneath the leg to get the elevation up in order to help pull the edema out of that area and reduce that amount of swelling and puffiness in the area, right? With the head, it's no different. I wouldn't want them laying flat in bed. I wouldn't want them laying flat supine. I would elevate the head of the bed so that I'm elevating the head, which will help pull some of that edema and stuff out of the face area and everything else and help to reduce it a little bit. So, just things to think about a little bit. So anyhow, with the client education, so this is, if you think about it, education is a big part of what we do as well. Of course, remember, as far as being an LVN, right, the RN is the one that does initial assessment, and the RN is also the one that is going to be doing the discharge teaching and everything else. But remember, as an LVN, we're able to contribute and to assist, and we can reinforce discharge teaching. We can reinforce the education that's been given, and we have to do that a lot of times because you'll find out that a lot of patients, they have all this stuff going on and everything else, and even when they're getting discharged and all, they do the teaching and they only hear it one time, and you'll find out that, 60-70% of what they were told, they won't remember just because of the circumstances going on. So we go back in and we reinforce it with the patient to help them keep it. Just like when I was working in oncology, right? We'd have a patient come in, and of course I always love some of the primary cares for chickens because they didn't want to tell their patient they had cancer. They would send it to us. I always knew when we had a problem because if I happened to be rooming the patient because my back office wasn't in or something, and or the patient's even checking in, they say, well, what's oncology? Then I'm like, oh, crud, this person has no idea why they're here because oncology, we deal with cancer. And then, I look at their chart and all of a sudden I find out they got stage 3 cancer, stage 2, stage 4 cancer. And so now we got a problem because I know as soon as the doctor says this, it's going to rock their world. And of course, I'll give the doctor the heads up that, hey, this patient has no clue. And even if they do have a clue when they come in, the doctor's going to get details to tell them where they're at and stuff. And then what happens is their world gets rocked. And when we get ready to do chemo treatments or other type of treatments that have to be done, a lot of times I'd be going in to do the education to reinforce what the doctor had told them and everything else. And sometimes I'd have to educate the patient 3 or 4 times. I would talk to them there the day that they left the office, and then when they come in to get treatments and all, we'd find out if they really didn't know what was going on. I'd have to sit there and re-educate that patient at that point in time before we started treatments because we just don't want to blindly start treatments because of their mindset where they're at. So a lot of times we also have to look at our patient's mindset. So anyhow, with client education, we want to reinforce teaching with parents about how to check urine for protein, review requirements for a low sodium diet, discuss medication administration and possible side effects. And if you think about that, any patient, and these are things we do for even adults, right? But anytime we got medications that we're given to the patient, especially if we want to take them at home, we're always going to have to talk to them about what the medication should be doing, right? We should be telling them about side effects they can expect, and we also have to educate about adverse effects, which they would need to contact the doctor about. That's something we have to do with all patients when it comes with medication. Reassure a patient that symptoms will dissipate as recovery continues. So it's basically the patient will be improving as they keep recovering from the condition. And then discuss ways to address social isolation and boredom. Because, immediately afterwards, they're probably going to be stuck at home and stuff. So, we would have to give them ideas of what the child could do or couldn't do in the house, and give them ideas of what they can do to defeat the boredom, and how to dress, with the child being isolated from other people, because, we don't want them around anybody sick or anything like that. And we also have to do that with adults as well. So basically, then we come into acute glomerulonephritis. So anyhow, are you guys doing good out there? I'm not going too fast for you.
No, it's fine. Thank you.
Okay. I figure a lot of this is review. And like I said, if you remember back to term 3, when you learned about the renal system for adults, you find out that a majority of what happens, you were taught about with adults, you find out that it comes in, we do the same things with the children. And that's one of the reasons why I did this one. I started off with it so that you would see that, so when you get pediatric questions, so you got a 5-year-old kid that has glomerulonephritis or something, you don't start freaking out going, hey, nobody told me about a child with this. Because, stuff like that happens, and you don't need any more stress when you're NCLEXing than you're already under. So anyhow, with acute glomerulonephritis, so basically, it's the most commonly and post-infectious disorder associated with pneumococcal, streptococcal, and viral infections. So anytime a child has these infections, and even adults, they could develop acute glomerulonephritis as a result of it. And a lot of that has to do with when we're doing the antibiotic treatments and all the shedding of the virus and everything else, then clogs up the glomerulus within the kidneys, and it creates the inflammation and everything within the kidneys, and then causes the kidneys not to operate appropriately. So thought to be a response to the deposition of immune complexes in the glomeruli. Excuse me. So you can see over here, you got your glomerulus basically going through your nephrons and all, and the glomerul in here. And of course, itis is inflammation, right? So anyhow, risk factors, my contributing factors, or basically risk factors, recent pneumococcal, streptococcal, or viral infections, most prevalent in summer and early fall, family history of the disease. And a lot of times here, I put in, like I said, some of the stuff you don't, with NCLEX are probably not going to ask you. But here with your risk factors, contributing factors, basically, you need to be aware of that, because, they could sit there and tell you that you have a 8-year-old child that had pneumonia recently, and then they start, giving a description of what's going on with the child, and then they're going to ask you maybe what you need to do and stuff like that. Well, if you understand a little bit about the contributing factors and the A and P, basically of the condition and stuff like that, then what happens is you're able to put it together and go, oh, this person has glomerulonephritis, and then you can sort of work with it. So anyhow, basically, once again, expected findings: edema of the face, worsens in the morning, spreads to the gonads, abdomen, and lower extremities throughout the day. They have anorexia, where basically they're not eating, and severely decreased urinary output. And so if you think about it, if I have decreased urinary output, then basically what I have happening in the body. You got any ideas?
You're swelling.
Yeah, basically, and that's what's going to contribute with the edema and all. If I have decreased urinary output, remember, the kidneys are the primary control of water balance in the body, right? So if the urine isn't coming out of the body, it's staying in the body, so they're going into fluid volume overload, right? And also, too, if you think about this, another way to think a little bit, too, depending upon the severity, right? Our urine, isn't it acidic, right? There's ammonia and stuff that comes out, so all that product could be getting stuck in the body as well, which could also impact my pH balance as well. So these are things that we need to be aware of. So expected findings. So it could be cloudy, smoky brown urine, often described as tea or cola color. And I'd be aware of this here. And as you see, I've bolted some stuff. because they may just put on there that the person has tea-colored or cola-colored urine, and then they go into whatever else in the question. So if you realize here with the glomerulonephritis, tea or cola-colored urine is an indicator of glomerulonephritis. Now you got an idea what you're working with the question. It makes it a little bit easier. Once again, you got proteinuria and hematuria. So basically with this, we got protein in the urine and we got blood in the urine. So, you know, when we're doing a dipstick and all, we'll be looking to see if we got protein and blood in the urine, which shouldn't be in the urine. And of course, if I got urine in the, if I got protein in the urine, remember that's going to be albumin and stuff. So that also is what's causing the edema within the body, because then once again, as osmotic pressures in the vessels is not there because there's not adequate amount of protein, so fluids leach out through the capillaries into the interstitial tissues. So they could decrease glomerular filtration rate, headaches, abdominal discomfort, dysuria, so basically, you know, difficulty urinating, lethargy, irritability, and pallor. So expected findings, basically we see mild to moderate increase in blood pressure, so the blood pressure can elevate. Azotemia, basically high levels of nitrogen and waste products within the blood. So that's what that is, azotemia, basically, azotemia. Can have elevated streptococcal antibody titers. And of course the titers just where they draw the blood, spin it down, then they go and look at it. And they look at the antibodies basically that are in there, and they can see if they're real elevated for streptococcal. Decreased glomerular filtration rate, decreased serum complements C3. So basically it goes just there. So levels return to normal at 8 to 10 weeks after the disease. So these are just some of the expected findings. They can also have hyperkalemia. So basically, right, that's high potassium levels. And of course you got to remember, right, if the glomerulus and the nephrons and all are inflamed, right, stuff that should be getting out of the body isn't necessarily getting out of the body, like I said. So, and I always forget about the potassium off and on, but basically, if they're not voiding, then what happens, like I said, one, they go into fluid volume overload, but also, just like somebody on that has end-stage renal or whatever, the potassium can't get out of the body, so potassium levels are going to elevate, so we'd have to monitor that closely. And as I said, right, urine is acidic, so if the urine isn't coming out of the body, that's going to impact the pH balance, so it can put them into acidosis. And of course, they can end up with low calcium and high phosphate phosphatemia. So if you remember, my calcium, my phosphates work in a reverse ratio, right? So if the calcium is high, the phosphates are low, and if the calcium's low, the phosphates are going to be high. So, and that's why these two get there, because these two work sort of hand in hand, but they work opposite of each other. So the calcium goes low, so the phosphate is going to be elevated. So anyhow, generalized cardiac enlargement, pulmonary congestion, and pleural effusion during edematous phase. All right. So, you know, there, you know, cardiac enlargement, so the heart can get enlarged. Basically, they can have pulmonary congestion. So if you think about pulmonary congestion, you know, we can start seeing fluid building up in the lungs. And then the other one that we got pleural effusion. So y'all remember pleural effusion?
Yes.
That's where fluid builds up on the pleural space around the lungs. So basically, you got your visceral and peripheral pleura that goes around the lungs, right? You got that little space in there with serous fluid, if you remember. And so basically, there's an overdevelopment of that fluid in there. That creates a pleural effusion. And what is the risk factor with a pleural effusion that we'd have to be monitoring for? Anybody know? You guys are not answering tonight, Sitting in the background, you'll have to talk it all out. Okay. So the pleural effusion, if it develops, it could be a small one, which won't be a big issue. But if it gets large, then basically we can end up with echolacsis. Basically, it can collapse the lung tissue, and then they may have to do a pleurocentesis, basically, where they're going to pull that fluid out of the pleural space to stop the lungs from collapsing. And remember, if that develops, right, we're going to see the person, they're going to have shortness of breath, difficulty breathing, they're going to have a rapid respiratory rate, rapid heart rate, and they could have, if it gets real bad, then they can have a feeling of impending doom. Basically, they can feel like they're dying. So, this is what we know this could develop. So this is something we need to monitor for when we're auscultating the lungs. Now, we won't hear pleural effusion, but what will happen is if it's getting a large pleural effusion, what's going to happen is that the lungs are going to collapse. So when we put the stethoscope where the lung tissue should be and where we should be able to hear breath sounds in the lungs, we're not going to hear anything, or they're going to be super diminished because of the lung tissue being having pressure put against it and collapsing it. So there's just a picture with the glomerulonephritis up there. Sort of just goes around. I'll let you leave it there so you can sort of look at it. I don't need to read all of it. And once again, just like last night, when I get done and all, if you do want a copy of the PowerPoints, I'll post my email again in the chat box so we can get it done. So if you want a copy of this, you can just sit there, shoot me an email, and I'll attach it and send it back out to you. So with acute glomerulonephritis, so the laboratory tests, diagnostic tests, and stuff that we're doing. All right, so one, we're dealing with the kidneys, so I know right off the bat I'm going to have a urinalysis. Basically a BUN, which, they're going to look at the BUN, so that's going to be a lab draw. Because electrolytes are impacted because of the kidney problems, we're going to look at electrolyte panels, basically, especially paying particular attention to the potassiums, calciums, basically, and phosphates. And then, of course, you got the N-types, streptolysin, titer, basically serum complement levels, and, of course, a chest X-ray. And if you think about it, you might be thinking, well, we're dealing with the kidneys, fluid volume, and everything else. But basically what they'll do with the chest X-ray, if you think about it, because the kidneys, are they located in the chest? No, right? They're located in the abdominal cavity in the back, right?
Yeah.
And so the reason they do the chest X-ray is, remember, the pleural effusion. So they'll do chest X-rays to make sure that the pleural effusion isn't developing, because then that can directly compromise the respiratory system, and then they could really have problems, because now the child, or if it's an adult, they're now going to end up dealing with two problems, because they're dealing with a renal issue, and then if they get the pleural effusion, now they're going to be dealing with a respiratory issue, and basically that could overwhelm the patient. So basically therapeutic procedures, basically in medication, so sodium and water restrictions if output is significantly reduced. So we're going to cut back sodium. Now one thing, if we reduce sodium, basically, right, we're going to tell them not to use sodium, right? So if somebody can't use sodium, parents say, oh, I can't use sodium, what do you think you're going to go out and buy for the child, especially if they use sodium to flavor the food with? Because most of us use too much sodium as it is, right? Don't they have sodium, or basically salt substitutes? And the one thing you have to watch out is in salt substitutes, one of the main ingredients in those to give it flavor is potassium. And so you have to remember that if they are going to have high potassium levels anyhow, we don't want to introduce any more potassium into the body. So basically, when we talk about sodium restrictions, we're also going to have to let them know that they shouldn't be using salt substitutes, because those normally have a lot of potassium in them, which would be detrimental. So they're going to have to use different types of seasonings like herbs and stuff like that, something that doesn't have potassium in it, because that could put the child into critical conditions if the potassium level gets too high. Water restrictions, so basically they may cut back the amount of water that the child is allowed to have. And if they're in our care, you got to watch out, because if we do water restrictions, they can get quite strict depending upon how reduced the urine output is. And so, you know, if you think about it, if they sit there and say the child can have 1,000 mLs a day of fluid, right? So if you take that and you do 30 into that, you know, that comes out to what? That comes out to about 30 ounces. And that's not a whole lot of fluid, right? And that fluid includes everything, IV fluids, medications, fluids they have with meals, and everything else. So basically, we would have to plan our day or plan the fluid out with all the different activities that's going. And they may only be able to have a sip of water when they take the pills, and they may just be able to have a sip of water when they're eating. And typically, if it comes to water restrictions, if you see a question like that, normally we give 2/3 of the fluids during waking hours, and we save 1/3 for the evening hours. So if they have a med pass or whatever at nighttime, then we have fluid that we're able to utilize for them to be able to take the pills at night. So just things to think about. You got diuretics unless renal failure is severe, antihypertensives, and if you remember, right, one, the heart can be impacted, but the other thing is also, remember, does the kidneys play with blood pressure? Yeah. Remember the renin-angiotensin converting enzymes and all, right, that comes out from the kidneys. That helps control it. The kidneys are having problems, so they can have problems with that. They can increase blood pressure. Also, the fact that they're retaining a lot of fluid, that can also increase blood pressure. So, you know, they can be put onto antihypertensive medications. Antibiotics for persistent streptococcal infections. And then, of course, fluid restrictions if glomerular filtration rate is significantly decreased. So here, as we continue, right? So one, we want to encourage activities as desired. And also, basically, I'd put as tolerated. So we want to encourage activities, but we want to do it within the range of what the patient can tolerate, because if they do too much, then that would be detrimental. And of course, we're dealing with fluid volume because of the kidneys, so I know, just, you know, we do this with every patient, right? Daily weights. And then, of course, monitor vital signs, level of consciousness, and changes in behavior. And of course, as you see down here with this glomerulonephritis, basically they're going to limit sodium in the diet. Also, they're going to limit potassium if they got oligarchy. So basically, if they're not voiding very much at all, basically urine is scanty, then basically we will go on to potassium restrictions because of the fact that potassium is being retained in the body. Here we want to, with the acute glomerulonephritis, we want to limit proteins with severe azotemia. So like it says, the azotemia, basically high levels of nitrogen and the waste products in the body. So when the body breaks down proteins, it creates nitrogenous waste. It also creates ammonia as a byproduct of protein breakdown. So basically, if they're having this condition going on, then basically we need to limit the protein, because the protein is going to continue to keep putting all these toxins into the body that aren't getting out of the body, and then that can become life-threatening. Note volume and character of urine. So, you know, we'll be doing strict I's and O's on this patient, but also when we do the I's and O's, right, we're going to be looking at how much urine they're putting out versus how much fluid they're taking in. But also we want to look at the urine. See, is it, you know, is it dark colored? Is it full colored? Does it have a foul odor to it? Is there, you know, is it clear? Is it cloudy? You know, that's the characters of urine that we also need to be looking at and documenting, basically, and keeping either our RN or our doctor that we're reporting to, keeping them informed of what we're seeing as we assess the urine. Of course, monitor intake. So like I said here, we're going to be doing intake and output very closely. If fluid are restricted, evenly divide fluids while the child is awake, served in small cups, because they're going to get very small portions. like I said, most of the times, they give 2/3 basically during the waking hours. They may give a little bit more than that, and then they keep some on reserve so they have to take medicines at night because, basically in the hospital we give medicine around the clock. So we need a little bit of food for them to be able to take at night. Monitor the skin, elevate edematous parts, which we already talked about, encourage frequent movement and repositioning. So if you think about it, here we're talking about children, so most of the times the children, they can be little wiggle worms in bed, so that's good. And of course, if they're not really moving because they are too fatigued or whatever like that, then of course we have to do our normal repositioning on them, or we do it at least every 2 hours. And of course, have a dietary consult. UTIs, so basically once again with that, right, infection of the lower urinary tract, so it could be the urethra or bladder. Basically upper urinary tract, so it could be the ureters, kidneys, or both. So it could be the lower or the upper kidney tract, basically, the urinary tract. So diagnostic factors of pyuria and at least 50,000 colonies per ml of a single pathogenic organism in a clean catch or sterile urine specimen. And that's sure, coli is responsible for 85%, so it's just giving the main cause of this. So basically, if you watch, a lot of people, if you've ever had urinary tract infection stuff, they can have abdominal pain. They can get intense burning, basically when they void and stuff. Of course, keep in mind, with children, that goes along. If we're talking about older adults or geriatric adults and all, when they get a UTI, a lot of times they don't get the pain and the discomfort from it, but they can get confusion, they can get bedwetting, and they can start having trips and falls basically in there. So just so that you're aware of that as well. So our contributing factors or risk factors, so one, female. So females are at high risk for UTIs, basically, and the main reason being because the urethra is real short, right? And so basically, and remember with that, that's why we always teach female clients when they wipe themselves, they always go front and back to help minimize the chances of a UTI. Basically Caucasian, so basically uncircumcised males, the one investigated corporeal, whatever, reflux, sexual activities, masturbation, inadequate fluid intake, incomplete emptying of the bladder resulting in urinary stasis, dysfunctional voiding. So, with older clients, if they have BPH, benign prostatic hypertrophy, they can be at risk for UTIs, urinary tract abnormalities, constipation, and of course, catheters. And of course, we know that using fully cast and straight cast, high risk of a UTI. So constrictive clothing or diapers, synthetic underwear, prolonged wearing of wet clothing. So, and like I said, if you watch, a lot of this falls right in line with what you learned in term 3 with adults. It's the same thing for the children. So, we don't, when they wear underwear, we want it to be cotton underwear. We don't want that synthetic fabric because basically it causes the person to sweat a lot more. It doesn't pull the sweat and everything else away from the area, which then can make it more prone, and it also generates heat, so which makes perfect breeding ground for bacteria and stuff, so that an infection could happen from that. Then you got pinworms, bubble baths, hot tubs, and whirlpools are also risk factors for UTIs, and of course the beginning of toilet training. So with the young children, when they first start learning how to use the toilet, that also puts them at a high risk, especially if they have bowel movements and they wipe themselves wrong. If it's a little female girl, then of course that can create a problem as well.
Oh.
So there's just a little bit of another one there. So like I said, if you want to copy the slides, you can just email me here. I'll put it in at the end and I'll send them out to you. So our expected findings, what we'd see, so right, thick, cloudy urine with mucus strands, pyuria, at least 10,000 white blood cells per ml of uncentrifuged urine. So we can see the pus and stuff floating around in the urine. Bacterial growth in urine culture. So if we do the clean catch or basically sterile void, then basically we can see when they go and culture it, they can see the bacteria that's actually in there that's causing the problem. Remember, my urine, it should be clear, it should be amber or yellow, and it should not have a foul odor to it. It should be aromatic, so it shouldn't smell foul. So, if it does, then there's problems, right? So if you know what your normal urine is, then you'll be able to tell if you have a problem with the urine. So with infants, basically, they can have irritability and lethargy. Basically, so they're not going to be wanting to sleep and stuff, or they could be really sleepy or lethargic. Basically, screaming with urination, because normally, when we're younger, if we have one, it can create a lot of burning when we void. Poor feeding, vomiting, and diarrhea. They can have a fever. Newborns can exhibit fever or hypothermia. So basically, it could go two ways. They can either have an elevated body temperature, or they can have a below normal body temperature. They can develop jaundice, cyanosis, and tachypnea. And of course, the other thing with the UTI, basically, especially when it gets bad, they can have hematuria, basically blood in the urine. Basic children, they can have abdominal flank and back pain. We think they can also have that as adults. Dysuria, difficulty urinating, hematuria, blood in the urine, incontinence, and previously toilet-trained children can happen as well. So you need to be aware of that. So just like I said, with the older patient, they can become incontinent, and with the younger patient, with the young children, they can also become incontinent as well. And then inuresis, basically. So basically, like it says, their definition, inability to control urine. So this is where you got a child that's being potty trained, and now all of a sudden at nighttime they start having bedwetting and stuff of that nature instead of getting to the bathroom. Male clients can dribble urine, straining to urinate, high fever, severe flank and abdominal pain, and leukocytosis are symptoms of pyelonephritis. Clients can be asymptomatic or display symptoms inconsistent with urinary tract infections. So, they could have respiratory or gastrointestinal issues with it as well. So asymptomatic. So basically not normal signs of a UTI. So there's just a picture up there showing a little bit with it. So, most of the times when people get a UTI, basically they do have burning and painful urination. It can be extremely painful. Basically, and of course they can have frequency of urine. Basically, they constantly feel like they have to urinate. And of course, the urine's cloudy, foul smelling, and of course they can have pelvic pain, especially the women. So, some of the things to think about. So with the diagnostics, of course, we're dealing with urine, UTI, we're dealing with the urinary system, so we know urinalysis is going to get done. They're probably going to do urine culture, which would be a clean catch, or basically your midstream catch, basically your sterile urine, or, as sterile urine as we can get. Urethrocatheterization, so, they may, if the doctor wants it to actually be sterile, get it, then he may order us to do a straight cath to collect the urine directly out of the bladder, a bladder washout, renography, so we can take x-rays of the renal system, ultrasounds, voiding, cysto, urethrogram, so these are some of the different types of tests, intravenous pylography, and the dermacaptos, I won't pronounce that one right, so, and that's another scan that can be done. So basically here, therapeutic, once again, antibiotics to be used, and of course IV pyelonephritis, Analgesics, yeah, well, it's antibiotics for UTI. If they got pyelonephritis, then they'll be getting IV antibiotics. Analgesics to treat the pain and the treatment of contributing anatomic defects. So if they have an issue, something's anatomically not right, then of course they'll have to go in and fix it. So our interventions basically ensure that clean catch urine specimens are collected properly. So remember, with our clean catch, us trying to get as close to sterile as we can. So this is where we get the 3 wet naps, if you remember, right? And we have them wipe it, if it's a male, they'll start the glans meatus, the head of the penis, and they will wipe down the shaft. And so they'll do a circular motion. And so they'll basically do that 3 times. If it's a female, they write when they do it down there with their labias, they go right side, left side, and then up the middle, and then they continue to hold the labias apart while they void, so that basically we can get the cleanest specimen that we can. Remember, when they void, they're going to start voiding, and then they're going to stop, and then put the cup in, and then start to stream again, so they can get the urine, because we don't want the first urine that comes out, because that could have other stuff in it. Basically, and that's why we have them void first. The same thing with the male. We'll start them voiding first, and then they stop and put the cup in, and then collect the urine. And of course, the thing is, if you're out there too and you're working, females, they're pretty good at being able to stop the urine and then put the cup in and then restart it. With men, most of the times, once they start going, they go, and they typically don't stop it. So basically, when they go to do it, they're going to slide the cup into the urine, so basically the cup will probably have urine all around the outside, even though they may wipe it down with a paper towel. And so remember, that's why anytime we handle specimens, we always wear gloves. Don't ever take a specimen from a patient without gloves on. I used to have that in the office, and we'd have to get some people who had renal cancers or whatever like that. We'd have them do a urinalysis for us to run on our urinalysis machine in our lab that we had set up in the practice. And they come out of the bathroom and walk down the hall with the urine specimen in their hand after you told them to leave it in the bathroom. You go get it, and they want to give it to you. It's like, hold on, because then I have to go find some gloves to put on so that I can take it from them. And they don't always understand that. So they have collect first morning urine for analysis, assist with suprapubic aspiration, or collect catheterized specimen for culture, and encourage adequate fluid intake. So during this, we still want them to be drinking the 2,000 to 3,000 mLs a day. Encourage frequent urination and complete emptying of the bladder. Monitor urine output and characteristics. So basically, once again, and we're going to be doing eyes and nose on this patient, but once again, we're going to be looking at how much urine they're putting out versus how much they're drinking in. And of course, we look at characteristics. Is it cloudy? Is it clear? Is it smelly? Is it, discolored? Is it super dark? Or is it clear amber or clear yellow? Administer mild analgesics as needed, and encourage a high fiber diet. So this is just sort of showing a little bit, basically, for doing the clean catch. So basically, education, reinforced teaching with female clients from right front to back. So just always remember that. Reinforced teaching about double voiding. So urinate, stop, and attempt to urinate again to ensure adequate emptying. So basically void. Once you stop, basically, then wait, then attempt to try and urinate one more time to make sure you get the bladder completely empty. So reinforce the importance of wearing cotton underwear and non-restrictive clothing. Demonstrate how to retract and clean foreskin if uncircumcised. Discuss the need to properly change out of wet clothing. You don't want to stay in wet clothing all the time because that can lead to an infection. Avoid bubble baths, whirlpool tubs, and hot tubs. And so this is because these can introduce bacteria basically into the urethra. And then, of course, if it gets into the urethra, Now we got a UTI. Emphasize the importance of adequate fluid intake. And that's important, adequate fluid intake is important for a lot of different conditions, right? We always want them drinking 2 to 3 liters of fluid, basically 2,000 to 3,000 mLs of fluid a day. And because when they're doing that, then the kidneys are running it through, and it sort of helps flush the kidneys out and keeps everything sort of clean and moving right along. Encourage sexually active adolescents to void immediately after intercourse. And we also do this with adults as well, so that hopefully if any type of bacteria got in there during the intercourse, and if they can void immediately afterwards, that will help push it out of the urethra and minimize the chances of getting an infection. Emphasize the importance of completing antibiotic regimens. And of course, you probably had that in pharmacology as well, which, probably got beat into you. So, that's very important because a lot of times people will sit there, start the antibiotics and take it 4 or 5 days later to feeling better, and they think they'll keep the rest of it. So if they have another infection and they got there and don't have to go to the doctor. But the problem is antibiotics prescribed for the specific length of time, it's going to take those antibiotics to kill all that bacteria. So if they stop it short, then what happens is that some of the bacteria is still there, it's going to replicate, and then it's going to sit there and cause a problem, basically, because then what can actually happen is the antibiotics can then become drug resistant, or the bacteria become drug resistant to that antibiotic, which then creates a major problem for people. And, I've seen that happen. I've had to educate my patients on that as well, because you'd be surprised at how many people will do that, and unfortunately they end up with problems, or they get the rebound infection, and then it's harder to take care of. Emphasize the importance of completing antibiotic regimens. So, once again, there's just some talk about preventions, right? Clean the genital before and after sex, urinate immediately after sex, wash your rectum daily, basically drink lots of water, don't hold your urine in and stuff. And unfortunately, going to be nurses out there, unfortunately, you've probably heard about the nurse bladder. I'm older, I got BPH, and I don't have a nursing bladder. I haven't had one for a long time, but, I used to be able, I could go the whole day and never go to the bathroom. And then when I'd finally get home, I go in the bathroom, I could probably dump out 2 liters of urine. Just because I'd be so busy and working all the time, I just never got to the bathroom. And a lot of nurses do that. Unfortunately, that's not good to do because that increases the risk of a UTI. And I've had a couple over the years, and they're not pleasant. Let's see, respiratory disorders, basically tonsillitis. So basically, this typically hits the young, the children, but it can also hit adults as well. So tonsillitis refers to inflammation of tonsils, which are usually accompanied by pharyngitis and often caused by a virus or bacterium. So as you see, basically, it shows here, but either way, if you watch, tonsils normally tuck up in there so you really can't see them. And of course, when you get tonsillitis, inflammation of the tonsils, then they swell up. Basically, so when we look in there, we can see them. So basically, exposure to the contributing or risk factors, so exposure to pathogenic organisms, increased susceptibility in younger children due to immature immune systems. Remember, when children are born, there's still stuff that has to develop, and their immune system takes quite a while to develop. And that's why with the newborn, we want the mother to breastfeed at least for 3 days so that they can get their mother's antibodies into them to help protect them for the first 6 months of their life. But it takes a while for the children's immune system to develop, so they tend to be more susceptible to a lot of different types of infections. So expected findings, so halitosis, bad breath, basically they can have snoring, nasal sounding voice, fever, difficulty swallowing and breathing, mouth breathing, edema, inflammation, erythema. Of course, you can see some of the other ones: persistent cough, difficulty hearing due to blocked eustachian tubes, throat pain that worsens swallowing, and of course, possible positive throat culture for group A, beta hemolytic streptococcus. So pictures out here below, so that if you do it visually, of course you can proceed to associate with the different things that is going on, what's going on. One in, it took tonsils out right away, but as medicine evolved, we found tonsils are lymphatic tissues, so they're part of the immune system. So now they tend not to remove the tonsils unless they have so many episodes of tonsillitis in a year, or the tonsils have swollen up so large that it's going to impact the airway. So nursing interventions with tonsillitis, we want to have soft or liquid diet, cool mist vaporizer, cool liquids, warm saline gargles. So these are some of the things, and if you think about it, if you watch, right, we got cool liquids, and even when they're doing the soft or liquid diets, they tend to make it cool, because if you think about it, we got itis, right, inflammation of the tonsils. So what's going to make the inflammation better? If it's hot, would that make the inflammation better or worse?
Oops.
No, heat would make the inflammation worse. So if we can give them cool liquids and stuff of that nature, that can help reduce the amount of inflammation and be more comforting basically to the child or adult that has it. So prepare the child and parent for surgery. So ensure consent forms are signed. Note bleeding tendencies. So basically when they do this, they're going to do the PT, Pt2, INR, and a few other clotting studies on there, because they don't want to go in and remove the tonsils if they're going to bleed out. Basically obtain baseline vitals. So basically, we get the baseline. When they come into the hospital, we get their vitals right then and there. And of course, also, if you remember in your pre-op teaching, all right, we get vital signs prior to them going into surgery, so we can compare vital signs when they come out of surgery. Report any symptoms of an upper respiratory infection, and report loose teeth. So, because if you think about it, basically, upper respiratory infection, well, if they put them under a general anesthetic and they're laying in there unconscious, they can make the upper respiratory infection a whole lot more severe, because of the fact that the lungs aren't really going to be working very much. And same thing, young children, they can have their teeth being loose because they got permanent teeth coming in, and the last thing they do is to have the tooth fall out, go down the throat, and then create an obstruction in the respiratory tract. Discourage coughing, clearing the throat. This is post-operatively. So, if you think about it, we don't want them to cough, clear the throat, or blow the nose. And if you think about it, that's because it increases pressure in that area, and they're going to have sutures in there, and so we don't want them to break that suture line, because then they can start hemorrhaging and everything else. And of course, there's monitor for signs of hemorrhaging, and I'm sure that when you learned about this back in respiratory, right, if you think about it, frequent swallowing, repeated throat clearing, basically hematemesis, but the main thing here is if I have a child in there, or even an adult, and they've had any type of throat surgery, if you come in and you see they're swallowing or constantly trying to clear the throat, which is not what we want to do, because that can rupture the suture line in there, can rupture sutures. But basically, typically, if there's no reason for them to be doing that, then that can indicate that basically they got hemorrhaging, because blood's real thick, and so it will cause that where they're going to try and swallow, trying to push it down or clear the throat so they can try and bring it up. So with that, if you've ever had a real bad cold and you got a real bad postnasal drip, if you remember when it's going down the back of the throat, you'll sit there, especially if it's nighttime, you're laying down trying to go to sleep, then all of a sudden you're trying to swallow it all because it feels like you got all that stuff hung up in your throat, and you're trying to swallow it down, or you start hacking, trying to bring it up and get it out of your throat. And of course, hematemesis, that would be a dead giveaway. So this is where they vomit blood. So if they're doing any of this here, this is something that definitely has to be reported immediately. Monitor for airway obstruction. So basically we did surgery on the throat, basically to get to the tonsils. So we're going to be monitoring for any type of obstruction. They can have swelling in that area that could close off the airway. And so they could have stridor, they could have drooling, restlessness, agitation, tachypnea, and cyanosis. If you watch the restlessness, agitation, tachypnea, and they get tachycardia going as well, these would be my earlier signs. A cyanosis would be a late sign. Stridor would be a late sign. That means that you missed all the early signs and now we're in a fight for life. They may have to trach the patient. And same thing with drooling. Drooling would be a later sign. My early signs would be the child starts getting real restless, or they get agitated, or they got increased heart rate, or increased respiratory rate. Those would be early signs that we got a major problem developing. Position the client to facilitate drainage. So basically, if you think about, they've had surgery back in the throat area, just like with a thyroidectomy or anything there involving the throat or involving the head. We need to elevate that area to try and reduce edema and reduce swelling in that area. So we will have them in a Fowler's position. We will elevate the head of the bed. And it's not just during the daytime. Basically, when we have the head of the bed elevated, we'll always do that. We might come to a semi-Fowler's when you're sleeping at night, but they'll sleep with the head of the bed elevated. So, restrict food and fluids until swallowing with no signs of hemorrhage are observed. So if you think about it, we don't want them eating stuff that's going to go down there and irritate that area, causing more swelling in the area that could rupture the suture line. So basically, initially, they're going to restrict food and fluids until swallowing no signs of hemorrhage are observed. Basically, we'll offer ice chips, sips of cold water, cool liquids, and ice pops. So if you think all of this is cool, so this is to help reduce the inflammation and to provide comfort to the patient. Refrain from offering red or brown foods that can be mistaken for blood. So, basically they spit it up and, they had a red popsicle, and all of a sudden, they clear a throat or something, they spit it up, and though it's going to come up with a red tinge in it, and now it could be mistaken for blood when it's not, it's just a popsicle. So here also, basically, we can apply an ice collar around the neck to help reduce the swelling and provide comfort. And of course, basically, they'll start off with, a lot of times it'll be a clear liquid diet to full liquid diet. And of course, as they are progressing, then we can advance to soft foods. Basically, administer narcotic analgesics on a regular schedule. So these are some of the precautions we take after tonsil surgery. So, if you watch here, and of course this is for adults, not just for children, but like I said, if you watch, for the most part, you'll see basically what we do for an adult. Most of the times it's pretty much what we're doing for the children as well. So hopefully when you figure that out, when you get the questions, because saying you got a 5-year-old, you're not going to, get all messed up and think, oh, this is a pediatric question. They never talked to me about this with a 5-year-old. So we got bronchitis and tracheal bronchitis. So inflammation of bronchioles. So like it says here, it's the inflammation of the trachea, and the bronchi is usually associated with an upper respiratory section and caused by a virus or pneumoniae. Yeah, there we go. This is common in children. It begins with a dry hacking cough. It becomes productive in 2 to 3 days. Symptoms intensify at night. And if you really think about it, if you remember whenever you're sick, just think about it. A lot of times if you get sick, if you've had bronchitis, flu, anything else like that, if you watch, during the daytime, a lot of times you can operate normally, and then at nighttime when you're trying to go to bed, that's when it seems to get its worse. And so it's, that's why here it's no different. Sometimes I always say, if you've had exposure to this type of stuff, whether it's personally or other people, that's not the main thing because it's specific, but you can use that as a reference point so that you can attach to your knowledge to it so that you can readily pull it up when you're taking your test. So yeah, it is treated symptomatically with, so basically they treat the symptoms of this, so they can use analgesics, antipyretics, cough suppressants, and humidity. So they can use vaporizer. So they can use analgesics for the pain and antipyretics for the fever. They can give them a cough suppressant in the air. Cough suppressants can interfere with clearing of secretions. So with this is why I say a lot of times if you watch, if you remember, they can give regular Robitussin, and there's Robitussin with codeine. And codeine is a narcotic, and the reason it works so well is because the codeine suppresses the cough center in the brain. Right, where just regular Robitussin will suppress the cough receptors within the lungs with it, but if it got there and they need to cough to get stuff out, it will come out. So a lot of times during the day, they may just use a standard cough suppressant, as long as it doesn't stop them from coughing completely, because we want them to cough up those secretions in the lungs to get them out so they don't develop secondary infections like pneumonia, typically, and most of the times that's what we're going to use. Sometimes they may use like phenogrin or Robitussin with codeine at nighttime to help the child sleep or the adult sleep through the night without coughing their heads off. So, they can use it intermittently. But just remember a lot of times if they're coughing real hard, we're going to use a cough suppressant. They probably will, if they're bringing up, if it's real productive coughing, they may use regular cough suppressant. They typically don't use the cough suppressant with codeine because that suppresses the cough center in the brain, which then means that the person's not going to be able to clear all the secretions out of the lungs. And yeah, it usually resolves in 5 to 10 days. Adolescents who have chronic bronchitis should be screened for marijuana and tobacco use. So now we got bronchitis, most commonly caused by a respiratory syncytial virus, which is the most common lower respiratory infection in children and the most frequent cause of hospitalizations of infants. The parainfluenza virus and the adenovirus are also causes. So if you think a lot of times bronchitis, they can get upper respiratory infection. You hear people say, oh, I had an upper respiratory infection and it dropped into my chest. So, a lot of times they could get an upper respiratory infection that moves down into the lower respiratory system. So with this, and the thing we have to be aware of with bronchitis, and a lot of times I'll have to see, I can't remember if he goes into that, but a lot of times with bronchitis, depending upon the susceptibility of the patient, bronchitis can move from bronchitis and it can move into pneumonia, which then becomes a very serious event for the patient. So like me, I get bronchitis off and on. Basically, I haven't had it in a while. I pay attention to it because if I get bronchitis, I normally go to the doctor immediately. And people are going, why are you going to the doctor immediately? Well, I know from personal experience, I've had pneumonia like 5-6 times now, and I know when I get bronchitis, if I don't get a handle on it right away, in about 4 or 5 days, I'll end up developing pneumonia. So I just go straight to the doctor. I don't play with it. So like it says, and of course, remember with bronchitis, remember respiratory, right? You get the inflammation, so the mucous membranes all inflamed. Course, remember the goblet cells are there to produce mucus, and we always have mucus being developed, debris and stuff out of the lungs to protect the lungs. But when we get an infection, now we get bronchitis going from an infection all. Then what happens? The body goes into hyperdrive, and what happens is the mucous membranes end up swelling up. And of course, what happens? The goblet cells now start producing a lot of mucus in order to try and trap the invader, and unfortunately, that creates a lot of problems for us. The body's trying to protect itself, but it actually ends up creating a problem. So as you can see, there's a healthy bronchiole here. And of course, once they get the bronchitis, it gets inflamed. The mucous membranes get all inflamed, and they start producing a lot of mucus. And of course, then it starts blocking the air passageways. And, when you're dealing with respiratory questions, always remember, our main concerns is gas exchange and air passageways, because we need air to move down to the alveoli for gas exchange to happen. So if I have an impairment with the airways, then the air is not getting down to the alveoli for gas exchange to happen. So contributing factors, so one being male, younger than 2 years, is peaks between 2 and 7 months. Crowded living conditions and smoke and prematurity are contributing or risk factors for this. And of course, crowded living conditions, you see it in the news sometimes, especially in the lower income areas, in the different major cities, LA, San Bernardino and all. You may have 2, 3, 4 families living in a 2-bedroom house, and they got like 10 people, 12 people in there, and that can contribute to it. But even nowadays, the price of houses, even like where I live at, there's houses up here meant just for one family, but you got 2 or 3 families living in that one house because, they just can't afford to get a house or to rent on their own, so they all live in the one house. And of course, that makes it a lot easier for different types of infections and stuff to be passed around within the family unit very easily, especially with younger children. So with the expected findings, so they got rhinorrhea, so all that is a runny nose, pharyngitis, inflammation of the pharynx, so that's the inflammation of the throat. They can have fever, coughing, sneezing, possible ear or eye infection, irritability, and lethargy. Poor feeding or refusal to feed, so basically they're not eating enough or basically they just don't want to eat at all. When we auscultate the lungs, we can have wheezing and crackles and diminished breath sounds, basically because the air passageway is being plugged. Air is not moving through them the way it should, so that will cause diminished breath sounds, right? So if I hear crackles in the lungs, that tells me what? Do you all remember?
Fluid.
Right, that's fluid, right? If I have wheezing in the lungs, that tells me what?
Constriction.
What was that?
Constriction.
Yeah, there you go. That's narrowing of the air passageways. So we get wheezing when the air passageways are narrowing. And of course, so if you think that's why we can have both of these, because the mucous membrane swelling, right, is narrowing the air passageway, especially with all the mucus in there. So they're going to have the wheezing as the air is trying to go through that smaller passageway. And we get the crackles because of all the mucus and other secretions that are developing in the lungs because of this infection. They can have retractions and nasal flaring. So if we get chest retractions and nasal flaring, typically, we see this really well in children. This here, I always, I'm not going to say that it always is, but typically if I see the child having retractions and nasal flaring, I consider that to be a medical emergency because they are now struggling trying to get air in, and they could end up going into full respiratory collapse. So if they have retractions from nasal flaring, this is something I need to report immediately to my charge nurse or to the doctor because this is a serious issue, and definitely if they don't have oxygen on them, we're going to need to get oxygen on them, and they may need to go and do quite a few other interventions to keep them from going into respiratory failure. Dyspnea or dyspneic basically, so they're going to be having difficulty breathing. Of course, they're going to have tachypnea, and of course with this as well, they're going to have tachycardia going on, and they can have apneic episodes, basically periods of time where they're not breathing. Now also, if I have a problem with the gas exchange, so here gas exchange is being impaired because the air cannot get down to the alveoli for gas exchange to happen for the oxygen to get into the body. But also remember when this is happening, if the oxygen is not getting down to get into the body, right, then the CO2 that's being pulled out of the blood and put back into the alveoli, that can't get out of the body, right? And so basically with that, right, these patients can go into respiratory acidosis because the impairment of breathing. Depending upon the severity of the respiratory insult will determine the severity of the pH imbalance. So here they can have copious secretions, cyanosis, and of course tests on nasal pharyngeal secretions are positive for RS antigens. So here's just the respiratory syncytial virus, RSV. So it's going around with this little bit sore throat, wheezing, bluish color of the skin, difficulty breathing, fever, runny nose, dry cough, noises from the lungs, basically just going along. So as we go, bronchitis, basically, so tests, so they're going to rapid, fluorescent antibody, direct fluorescent antibody staining, enzyme-linked immunosorbent assays. So these are some of the tests, testing for coexisting infection. So, they may do a urinalysis, and they could do a lumbar puncture. They're going to do arterial blood gases and electrolytes. And so, with the arterial blood gases, like I said, right, anytime we have a respiratory compromise, if somebody is not getting good gas exchange, then they're going to be going into acidosis, right? Just like somebody that's hyperventilating, they're going to go into alkalosis, right? So if our breathing is impacted, we're going to be going into acidosis. So they'll do ABGs, or arterial blood gases, because they need to find out, where they're actually at, how much acidosis are they in. Because remember, it doesn't take very much of a shift in the pH balance to become a very serious event. So they can use bronchodilators are not recommended on this one. Oxygen, mechanical ventilation. So basically with this, they're having difficulty breathing at all, we're going to have them on oxygen. And of course, if they're going into respiratory failure, then of course they're going to put them on the mechanical ventilation. They're going to intubate them and put them on a ventilator. The ribavirin basically is the only medication approved for treatment for children hospitalized with RSV, controversial due to the high cost. And of course, corticosteroids, basically controversial, but may be used. So depending, that's going to be what the doctor does if he's trying to deal with the inflammation in the area. IV fluids, and of course the Glavas, I'm not going to pronounce that one, sorry. So, but you can see it's for prevention in high-risk children. So basically, if you think about it here, this says prevention in high-risk children. So if we have a child that's really susceptible to this or at high risk for this condition, then they'll put them on this medication prophylactically. And remember, prophylactically is preventative. Basically, it's not because they have the problem, it's because we want to try and prevent the problem from developing. So basically here with this, with the bronchitis, basically drop in contact precautions. So, basically we got it done on our PPEs. Administer oxygen if oxygen saturation is not consistently maintained at or above 90 after suctioning and repositioning. So you may have to be suctioning the airway, clear it out, because the child may not be able to bring the mucus up adequately enough on their own. Then monitor airway and breath sounds. Of course, limit visitors and number of hospital personnel. So we don't want, we want to let the child rest and everything else. So we don't want a whole ton of people going in and out of the room. Basically with that, and also with this too, remember, we're going to want to bundle our activities. So, we don't want to go in and say, oh, I'm going to do my vital signs. Now I'm coming back 10 minutes later. Oh, I'm going to do my head to toe assessment. And then come back 10, 15 minutes later, oh, I got to do the gown change, and we'll do the bed change. And then, you want to try and put it together so you can do several things. So you might go in the room, do the head to toe assessment and take vital signs. If the child's tolerating that, then you might want to change their gown, then come back a little bit later and then, make the bed and wash the child, or give the bed bath, and then change stuff so that you can leave gaps of time where the child can rest. and also that reduces the stress that they're under as well. Basically assigned only to a nurse who has no other at-risk patient. So basically what that means, this child is super sick here. This can go critical really, really quick. So, I don't want this nurse working with somebody who has pneumonias or C. diff or any of these other type of infections. We want her to be the nurse needs to be working with patients that are not infectious so that they don't accidentally bring any other bacteria or viruses into that room with the patient. Selection with normal saline before feeding and PRN. Encourage fluids, so offer small amounts, 5 to 10 mL of fluid frequently. Monitor vital signs and oxygen status. Encourage breastfeeding. Do not administer chest physiotherapy. So client education, scrupulous hand washing. So if you think about it, that's with everyone, right? We want to make sure that they wash their hands appropriately. Otherwise, thoroughly, not just throw it in the water and bring it out, dry it off, and say, I wash my hands. And the thing is when we're doing this client education, we're going to need to teach the parents and whoever else is coming to see the child how to do this so they will scrub their hands appropriately before they actually go in and visit the child. Discourage smoking in the home. Of course, remember, smoking is the first cardinal sin in medicine, and the second cardinal sin is alcohol. So those two are never good. Reinforce teaching about how to instill saline drops and suction with a bulk syringe. So now we have respiratory distress syndrome, RDS. So this is a condition of surfactant deficiency and immature thorax. So if you think about it, what's surfactant? What does surfactant do? Where's surfactant at, and what does it do?
Something with the lungs?
Yeah. Well, it's respiratory, so it's the lungs, right?
It protects the lining.
Yeah. So basically, surfactants in the alveoli, right? And the alveoli are the little grape sacs in the lungs, and that's where gas exchange happens at. Surfactant surfactant coats the alveoli, and what surfactant does is it keeps the alveoli from completely collapsing so that we can breathe appropriately. It's sort of like if you have, if you've ever had a party for someone and you went out and bought some brand new balloons and you try and blow those things up. If you remember, those things are really hard to blow up. You really have to huff and puff to get the pop up and open to blow air into them, right? And if you let all the air out, then you have to huff and puff again, trying to blow them up again, right? But if you blew them up and then you let the air out, but you don't let all the air out, and then you blow them up again, they blow up really, really easy. So that's what the surfactant does. It keeps the alveoli from completely collapsing. So as we breathe in and out, the alveoli inflate and deflate smoothly without causing us a lot of the stress trying to breathe. So if I have deficiency in surfactant, then what happens is the alveoli collapse all the way down, and now this child has to strain to try and breathe in, to try and get those alveoli to pop open so the gas exchange can happen. And that's why you have the point of viability, if you remember that, with your fetus, the point of viability, I believe it was 24 weeks. I'm not sure if it's changed or not. But that's why they figure at 24 weeks and after they got enough surfactant in there that they can survive outside of the womb. And of course, now we got man-made surfactant, so if we have them really pretermed and all, they'll give them this man-made surfactant to get their lungs hopefully working appropriately so that the child will survive. So with this here, they have insufficient surfactant, they have surfactant deficiency. So what's happening is it's not in the alveoli, so it's very difficult for the child to try and get air into the alveoli for gas exchange to happen. So basically, often referred to as the hyaline membrane disease, results in hypoxia. So if you think about it, hypoxia is cellular starvation of oxygen, and that's because the villi can't pop open very easily, so basically gas exchange is not happening. It is most common in premature infants. It is rare in drug-exposed infants or neonates who were exposed to intrauterine stress, preeclampsia, and hypertension. So you can take a look and you can sort of see the conditions. This one here you can tell really easily. They're real cyanotic. This one you see a little bit on the forehead and stuff. So normally with this here, they're going to be in the NICU. So they're going to be in the neonatal ICU. So contributing risk factors with this: prematurity, multi-fetal pregnancies that have had more than one birth, or more than one, anyhow, I'll leave it like that. Cesarean section, mother who has diabetes, hypoglycemia, cold stress, birth asphyxia. So, and that can happen, from the cord being restricted or trauma during birthing, family history, sepsis, cardiac respiratory abnormalities, premature rupture of the membrane, maternal use of depressants close to delivery. So with the respiratory distress syndrome, we can expect to see tachypnea, so they're going to be breathing rapidly, respiratory rate greater than 60 per minute. Peristernal, pericostal retractions, so they're going to have chest retractions, nasal flaring because they're straining real hard, trying to get those alveoli to open up. Labored breathing with prolonged expiration. So I try to pick this up. You watch here, I did this because see how the ribs are showing through here? That's a chest retraction. And you see how the chest is sunk in here? That's also chest retraction happening. And of course, I can only find the adult one, but if you watch here, your normal nostrils here, and then here's the third nostrils, and you see they look like trumpets. They're a lot bigger. And so that's what happens with a child. It's real pronounced. It's real easy to see when they have nasal flaring. And of course, they get the chest retractions, nasal flaring. That's something that has to be reported immediately. So I expect findings: inspiratory crackles. So when they're inhaling, we can hear crackles. When they're exhaling, they're grunting. They can have muffling. So basically, that's the picture here. I tried to put it up so that at least you can sort of see what it looks like when you hear the word, because I know it's always fun when you see a word but you can't quite figure out what it is. Low oxygen saturations, respiratory or mixed acidosis, and hypercapnia, which means elevated CO2, because they're not getting gas exchange to happen because of the deficiency in surfactant. So basically, with this, they can get ectalaxis, so that's the collapsing of the lungs. So that's sort of the picture over here, where you see the lung is collapsing in on itself. Basically, as condition worsens, they can get flaccidity. So what flaccidity is, basically not familiar with it. If somebody's real flaccid, that means, sometimes you can see that somebody gets an overdose of narcotics or whatever. So like you pick up their arm and you let go and there's no resistance. You just fall straight down to the bed. There's no motion or no resistance. Unresponsiveness, apnea, periods basically not breathing, decreased breath sounds, and central sinus. Diagnosis, because I can't get appropriate gas exchange, so we know they're going to do an ABG. They're going to do chest x-rays. That could be looking for the ectalaxis, basically culture of the blood, urine, and cerebral fluids, and of course blood glucose. Of course, I just posted this up here basically for our ABGs, stuff of that nature, so that you can see what it is. And of course, here's the I just do here. I messed up and I forgot what the range is for that I put there. I forgot to mark it. I'll have to go look that up again. But anyhow. So now respiratory distress syndrome, basically therapeutic procedures. So basically with this here, A lot of times, like you say, they end up in the NICU. That's where they want to be. They're going to have the child intubated, basically, or basically giving them oxygen depending upon the severity of what's going on. IV fluids. They can be NPO in acute phase, so then they'll have either NG tube feedings or total parenteral nutrition, which basically is feeding by IV. Exogenous surfactants. So exogenous, if you think about exogenous, means outside the body. So this is the man-made surfactant that we're going to nebulize into them to get it into their lungs, hopefully to get the surfactant level to where it needs to be so that they can start breathing on their own appropriately. Prophylactic antibiotics. So once again, prophylactic means preventative, so they'll put them on antibiotics to prevent them from getting secondary infections. Caffeine, intropes, electrolytes, sodium bicarbonate. So these are some of the therapeutic procedures. My interventions, of course, this is respiratory, and we know with the diminished surfactant level, we have to monitor respiratory efforts. We're going to be watching. Do they have chest retractions? Do they have nasal flaring? Are they grunting? Do I hear stridors or any of that stuff? And of course, we need to monitor our ABGs, our arterial blood gases. Monitor vital signs, pulse ox, basically color and pulses. If you think this here, we do on everybody, doesn't matter, right? Place in a prone position initially to increase chest expansion. So this is one time, prone position is not a real common position for us. And if you watch with young children, we're supposed to put them to sleep on their back, right, in a supine position. So when they're in this respiratory distress syndrome, basically initially we're going to put them prone, basically, because this here, as I say, is going to help with chest expansion. Suction only when necessary. So basically with these, we don't do them on a regular interval of suctioning, so we don't suction like every 3 hours or whatever. We suction when it is necessary. So basically they got a lot of mucus and all that, but they're not clearing, then we would suction that out of the way. Place client under radiant warmer or other controlled environments to eliminate heat loss and prevent cold stress. So remember, with our infants, they don't have real good thermal regulation at the time. So this is why, they'll put them into the radiant warmer, which you see a picture of over here, basically to prevent them from going hypothermic and going into cold stress, which would make their condition worse. Encourage parental participation in care. So basically, we want the parents involved in the care of the child, basically, and they can pump and store the breast milk so that it's readily available and assist with repositioning. Remember, a lot of times when it comes to young children and stuff like that, they're more comfortable with their parents, so we'll let the parents do as much as what is safe for the parents to do. So like teach them how to reposition it, so we'll let the parents do it because the child will be more comfortable with that. We can let the parents bathe the child and stuff and dress the child. So we'll let the parents do as much as what is safe. We'll encourage the parents to participate because that helps reduce the stress on the child as well. Orientate to the neonatal intensive care unit. So we basically need to let the parents know that because the parents are probably going to be all freaked out, basically all high, concern levels real high because of what's going on. So we want to orientate them to the neonatal intensive care, show them where things are, and also explain and let the parents know what the different equipment is that's attached to the child, and explain it a little bit because this can be very scary, especially when they got bells and whistles and everything else going on, just like we would a patient in the hospital. We want to explain all that so that we can reduce their anxiety levels and their fear levels. Explain all the procedures, encourage kangaroo hold. So basically kangaroo hold is skin to skin as conditions allow. So basically the child is able to be held like that. We want the mom or the dad to get up there and hold the child skin to skin. And then reinforce how to pump and store breast milk. You do not give anything by mouth to infants who have a respiratory rate greater than 60 breaths per minute. So basically with this condition here, if they have a breath rate greater than 60, they're NPO. We're not going to give them anything because then there's a chance of aspiration. And basically, or to children who have severe respiratory distress. Either way, because basically then they can aspirate, and that can make it very serious because then they get aspiration pneumonia, and you can put it on top of this respiratory distress syndrome, and basically that could be a fatal event very, very quickly. Oh, and we got done a little bit. So are you guys good out there? You still alive on me up there?
We
Yes.
still are.
Oh, okay. Let's see. Give me just a second. Ooh, what happened? I did something wrong. Give me just a minute. Oh, there we are. Okay. Okay. So I posted my email into the chat box. So if you do want to copy the slides, that's fine. Just send me an email. I will attach the PowerPoints and send them to you. Please make sure your name is in the chat box, just so I have a record of who was here. And I also forward that to Mr. Montano because he'll want me to send it so that he sees who all is here, putting in the extra time and everything to hopefully improve yourselves and give you hopefully better thinking. So is this helpful to you guys tonight?
Yes.
Yes, very. Thank you.
Okay. All right. Yeah, I always ask because it's not helpful to you. I don't want to waste your time. And so, you know, you got something, other ways of doing so. But like I said, it's refreshing and hopefully I'm giving you different ways to think with it because with NCLEX, it's all about, you know, you have to work the question and be able to think through the question to find the right answer. So it's just working with your thought process, you know, basically everybody likes to say critical thinking. I don't like to use that too much because everybody seems to freak out and say critical thinking, but we use it every day of our lives. That's why you're still alive now, because you didn't have critical thinking. You probably would have been out, you probably would have been checked out of this world when you're about, you know, 10 years old or younger. So anyhow, that's it. We're done. So I'll see you guys hopefully next Thursday. We will be continuing on next Thursday. I believe we will be playing with hematologic disorders. And so we will do that next week, just reviewing some of the hematological disorders for you guys. All right. So you guys have a great night. Have a great weekend. Remember to relax a little bit, but also remember to keep up on your studies so that you do it, because right now, it's the grindstone just like it was in term one, because now you're grinding to get to your NCLEX. So other than that, I'm done. So you guys have a good night.